Good afternoon. Assalamu alaikum, dear colleagues. I have been asked to present imaging approach to neonatal intestinal obstruction in the annual Congress of Radiology in Dhaka, Bangladesh, and thank you for the invitation. Let me tell you about my background. As an RSNA visiting professor, I'm native of Algeria, graduated from medical school in Algiers, did training in pediatrics in Algiers, followed by further training at Johns Hopkins Medical Institution in Baltimore, Maryland, USA, after a master's degree at Harvard School of Public Health. Then I turned to radiology with my education in radiology at the University of Pittsburgh, completed by a fellowship in pediatric radiology at the Children's Hospital of Pittsburgh. Then I practiced in different continents, first in Paris at Trousseau Hospital, before moving to Canada, being a staff and faculty at the McGill University Montreal Children's Hospital. Then in 2001, I moved to the Hospital for Sick Children in Toronto, of the University of Toronto, where I'm still presently active. My clinical and research areas of interest have been in general pediatrics, especially international pediatrics, and in imaging, especially in the GI-GU sphere, as well as musculoskeletal imaging. So the topic of neonatal intestinal obstruction is an important one for neonatologists, and pediatric radiology plays an important role in diagnosis and guiding management, as I hope you will see it through this lecture. And today we will review actually discussing the different etiologic mechanism of obstruction of the GI tract of the newborn. First, by recognizing the pattern of radiographic appearances, then also analyzing the different contrast study examinations, as well as the contrast enema studies that will be performed to solve the clinical problems. Hopefully we'll have an idea about the systematic approach in diagnosis in view of indications of specific treatment, with the examples illustrating either a medical or a surgical management of these conditions. So this entity actually is not frequent, but an important one when it comes to diagnosis, because intestinal tract obstruction in newborn constitutes a large bulk of the surgical activity in neonatology, and actually it is estimated that 80% of surgical emergencies in this age group are in this newborn. Because the prognosis of the medical/surgical condition depends on an early diagnosis, and because also the multiplicity and the nature of the different obstacles to the GI tract anatomy, hence of its normal functioning. So we will basically review three fields. First, basic anatomic and physiologic points which help us understand the underlying mechanism and the structure of the disease that we encounter. Then we'll open up a field of clinical and imaging basis in terms of science to build up our diagnosis. So this will be met in different radioclinical situations. First of all, some basic points. It's always nice to refresh our reflexes when we look at an X-ray of an abdomen of a baby with in mind those important features. Number one, we follow the air in the GI tract. So we'll consider the topography of the intraluminal air versus the water density of the abdominal structures, essentially the viscera, not forgetting about the bone structures. The second point is the assessment of the progression of the swallowed air, and this is characteristic. With the first breath extrautero, you get air in the stomach. In first few minutes, quickly you get some small bowel jejunal loops, gas filled. It estimated that at 6 hours the cecum could be identified with air present in it. The key timing is 24 hours. By 24 hours at most, air should be within the sigmoid, hopefully in the rectum. So we are talking about a gradual filling of the air within the GI tract, and then we get an idea about the radiographs with this intestinal gas pattern as described here, where we will start building up what is the normal pattern. Here, normal loops in a neonate, they are described as polygonal, homogeneous width, they look alike, and they are separated by bowel wall structures, which is more homogeneous, rather thin. And the air would be seen continuously from the stomach down to the rectum. One important feature is, contrary to the GI tract in the adult, in newborns actually we cannot differentiate a small bowel versus a colon, because a small bowel, when it is dilated, would look like a colon, and the colon, when it is not used, it's what we call the microcolon, very small. This is an interesting analogy that my colleague Alan Danneman likes to show the resonance, because we talk about polygonal pattern, and that's, if you are from South Africa, you think about giraffes and the mosaic pattern that the giraffe has, and this would be the air in the bowel loops separated by the wall. Now, abscess of gas in the rectum is not uncommon in healthy newborns. Number three, now that we are considering the luminal air in the GI tract, is that most of the time we expect three fixed points: the gastric air bubbles, the duodenal bubble, and the rectum. So those are like landmarks when we start to sort out the intestinal gas pattern in the GI tract. Now, when this GI tract appears to be interrupted, what happens functionally is that the distal loops are not used, so the caliber is small, microcolon. This is an important semiologic finding, that if we do enemas, we'll try to identify that point, which help us then make a strong basis for possible and most possible positive diagnosis. So to summarize, the air, we follow in mind how is it swallowed, and then we make statement: is it absent or normal or delayed? Having seen those landmarks, and then we have an idea about the level of interruption of the GI tract. This is basically best seen on a plain radiograph of the abdomen. Now we turn to clinical, because clinical findings are very important, although the patient doesn't speak, but few important clinical features are worth spending a few minutes on. The vomiting. Now the vomiting, quick sharp history should mention: is it precocious versus late? Precocious means probably the obstruction is close to the upper tract. Late, we would think about lower tract obstruction. Number 2, is the bilious vomiting present versus non-bilious? Then one make an assumption that bilious vomiting is probably obstruction just below the vater arm of the ampulla of vater at the duodenum level. Lately, the fecal with vomiting may imply the obstruction is very low, and it would happen in cases of Hirschsprung disease, for instance. Then the second feature for a newborn is the function, the emission of meconium, the first bowel passing. And actually, one would know what a normal meconium looks like. It's usually dark green color, viscous, abundant, and comes in early in life, within 24 hours. At most, within 48 hours, large amount of normal meconium is expelled. Hence, when it's abnormal situation of meconium emission, the meconium expelled is usually yellowish, firm, like chalky, of small quantity. So it would appear late, or actually no meconium emission. So this is the most common indication for studies, and then we would see a few examples. Then comes the clinical examination findings. A flat abdomen quickly should refer to a level at a higher location in the GI tract, upper obstacle, versus when the abdomen is distended, one may think this is an obstruction at a lower level. Then, of course, palpating a mass could relate to a real mass or to a visceromegaly, splenomegaly, hepatomegaly, or polycystic kidney disease. But in the GI tract, meconium peritonitis would be including a so-called pseudocystic meconium peritonitis, or we are facing a case of a duplication cyst with mass effect, or even a volvulus. Then one will not forget the perineum with the pathology of ano-rectal malformations. And of course, as a good clinician, hernia orifices are examined, because it has been seen cases where obstruction GI tract missed because of strangulated hernia. Then, generally speaking, a lot of other medical factors are worth knowing, especially to build up the conclusion for a diagnostic radiologic report, are as follows. If we are dealing with a premature, especially a small birth weight, beside the infectious, the vascular complication that one baby would have, think of the transient immaturity of the small bowel. It would be immaturely functioning. Number 2 point is the polyhydramnios that is often described on prenatal studies. Then, of course, one would think and expect a possible obstructive problem of organic nature, such as an atresia. A special case of a diabetic mother giving birth to a baby who will have quickly problems with the GI tract is the so-called left small colon syndrome. And then now a subgroup of babies with trisomy 21 will be prone for a pattern of duodenal obstruction. After the clinical foundations, let's now turn our attention to imaging, and first, historically, conventional radiographies, which would give us an idea about the level of obstruction, upper or distal, and then the pattern of obstruction. Classically, two views are obtained, one supine view, frontal, And then another orthogonal view, and different institutions have different protocols, either a cross-table lateral view or a left lateral decubitus view to help possible abnormal air in the peritoneum build up on the right side, close to the liver. Personally, I prefer this approach because you don't manipulate the baby, especially if the baby is intubated. And you notice that abdomen radiographs first is with a chest radiograph, because the GI tract actually starts above, from the mouth, from even the choanal zone, nasopharynx, and then build up to possibility of esophageal problem. And then our main concern is in the intestinal tract. Then we will find out where is the obstruction. So on the basis of aortic distension of bowel, and then the presence of fluid level on the cross-table view, for instance. But one has to be aware of the significance of the paucity of gas, or when you have too much gas distension, because paucity of gas could be physiologic. Immediately after birth, you just have only small amount in the stomach. A premature, or even if you put a baby procubitus, the air is expelled from the stomach. Now, pathologic condition where we don't see much gas is vomiting, because the patient vomits every content. If the patient is dehydrated, and of course the big classic entity is if we don't see any air in case of esophageal atresia. Also, when the babies are intubated and the ET tube is in the airway, but may cause some obstruction of the esophagus, not allowing any gas going down. When it comes to gas distension, it could be physiologic condition, too much crying, or in pathology, now we have an entity of esophageal atresia with TE fistula, and the air goes to the GI tract through the pathway of the fistula. When the ET tube is in the esophagus, of course, it may happen, and then of course in severe entity of enterocolitis. Now, where is that level of obstruction? So, few classic features. When we see double bubble with air on the radiographs postnatally, we think of duodenal atresia. This is the analogy to the double bubble on prenatal ultrasound, where you have fluid in the stomach and the duodenum. Or now, if we see only few dilated bowel loops, I did not say small bowel, but few dilated bowel loops, it may imply logically that we have to deal with a small bowel obstruction. Now, later on we'll find out if it's in the jejunum or if it's in the ileum. If we have diffuse obstruction, we think of lower obstruction. It could be mechanical obstruction, plugs, meconium plugs. It could be Hirschsprung disease. It could be functional disease of the severely premature and low birth weight baby. The worst would be the classical case of ano-rectal malformation. So the vomiting is a big clinical scenario, and if we have to put an emphasis on the value of radiographs, is that when we have at least two basic projections obtained, we have an idea, is it proximal or distal obstruction in the GI tract? This is important because the second step in the imaging approach would be to do a contrast study. In case of an proximal GI tract obstruction suspicion, an upper GI is the favorite approach. Otherwise, we do a contrast enema study. One important message is the bilious vomiting, and I used to tell my residents that each time bilious vomiting is in the clinical history, I have to think surgical emergency, because a volvulus, the complication of malrotation, maybe there, and it's very important to diagnose it very fast. We will see examples of that through contrast study of the upper GI tract, but nowadays more elegantly also with ultrasound, the so-called whirlpool sign. Now when it's non-bilious vomiting, then we have to deal with more frequent pathology, maybe just a malrotation, malfixation at the duodenum, or maybe we are dealing with a GE reflux, or maybe there is a duplication of the GI tract causing that obstruction. This shows early in life. Now, typically between 2 weeks and 3 months of age, then you would have a baby who would vomit every feed, and every successive vomiting is more projectile, more powerful. Think of pyloric stenosis, especially if it's historically it's a classic example, first male boy in the family. And then ultrasound has been leading now as modality of imaging versus the gold standard of contrast studies. We will see examples of that. So, just to emphasize again, the radiographs could help you decide an algorithm, either upper GI study or contrast study. Bilious vomiting, we have to do something very fast before the OR. So, contrast study, the NG tube is already there, and we will see that we have to take some precautions using water-soluble non-ionic contrast to pacify the stomach and duodenum to demonstrate it, or ultrasound study, because then we will look at the so-called whirlpool sign. We'll describe it in a few minutes. Non-bilious vomiting, then we have to think more quietly on the possible etiologies. Now, some images. Let's see here. We have a plain film, and I do see what I described, a single bubble. So gastric gas distension. You may tell me, is this 10 minutes after birth? If I tell you this is 1 day or even 2 days after birth, nothing goes through the pylorus. And possible etiologies, although rare, but one has to think of, gastric antrum web, which would behave the same way as a case of pyloric atresia. Now, plain film is enough here. A clinician would request maybe contrast study. Well, you may tell them, okay, I will use air as a contrast method. So you, through an NG tube, you push more cc's of air, and the air doesn't go more distally. So then you don't have all the nuisance of getting contrast, maybe vomiting, maybe aspirating. Now, when the baby is having projectile vomiting, that was the gold standard of contrast study through the NG tube, and then having that classical semiology of the pyloric stenosis, hypertrophy of the pyloric muscle, which clinically corresponds to the classical pyloric olive that good clinician would palpate, especially when the baby is quieter or under sedation, induction of anesthesia. Then that's the best opportunity to palpate a pyloric olive. But when it comes to imaging, we have the shoulder sign, secondary to the hypertrophy of the pyloric muscle. There will be delayed passage of contrast, and then we would have a train track sign, and then we get an umbrella sign of duodenum following that elongated channel. Nowadays, ultrasound is the gold standard. Usually, a pyloric stenosis would look at you when you do just a survey with a convex probe, but we favor a linear probe with a high frequency, using the liver as a window. Technically, you look for the level location of the gallbladder, and the pylorus would be there. One would measure the muscle, pyloric muscle thickness, and the length of the channel. Observe if there is any content going through, and actually this may be optimized by giving the baby to drink sugar water solution, which helps the acoustic transmission of the wave. Then we will measure, and we have some criteria: more than 4 millimeter muscle thickness, more than 40 millimeter length, no passage of content. This is pyloric stenosis. This is what on high resolution with color Doppler pyloric muscle would look like. It's very angry, thickened, hyperhemic. It's like an angioneurotic edema, which tells you the possible etiopathogyny of pyloric stenosis. The problem is not that simple, because we deal with babies of small birth weight or with premature who would have vomiting for many reasons, some of medical management like reflux, but when it comes to pyloric stenosis would be surgically treated. And actually studies have been done determining the correlation of the pyloric length with the birth weight and with the gestational age. And this chart is handy because when you have a baby of different weight and then act like vomiting, and we don't know how much is thick the pyloric to say this is pyloric stenosis, one would refer to these data, because then you would have with confidence saying, be able to say this is the pylorus is hypertrophic for his birth weight and for his gestational age. Now, a rare case, but I wanted to show you this one because the patient is having feeding intolerance, and when we take a classical film, one is struck by this discrepancy in size of the gas in the intestinal tract. This is more dilated than this. So we think about high level or upper proximal level of obstruction. Ultrasound is handy. So we go for a pyloric stenosis. Well, that's what we see. The pyloric channel is here. The muscle is not thick, but we have some soft tissue here. So is it intrinsic? Is it extrinsic? So we took back the baby 2 hours later, feeding him sugar water by mouth and observing the dynamics of it, and we actually see that the pyloric channel is not that thickened, but we have a pathology, intramural pathology. Now, for you who do a lot of ultrasounds, this echo texture is very suggestive of pancreas tissue. That's how we call the pathology on ultrasound, later on actually verified by surgery. So think of ectopic pancreas at the pylorus. Most of the time this happens at the duodenum level. So ectopic pancreas may cause obstruction. We are more familiar with the ectopic pancreas causing bleeding, as in Mecker's diverticulum, where you have mixture of pancreas and gastric tissue at that level. Now, since we are dealing with duodenum, one should be more familiar with the duodenum appearance on ultrasound. Here is an example of normal SMA-SMV on transverse view of the upper abdomen. And here is an example where we see third portion of duodenum crossing the midline to come to the left of the spine. And actually Dr. Youssef Zadeh from Chicago raised that topic because the classical wisdom was that we do an upper GI study to demonstrate malrotation and volvulus, but the experience shows that not every case of malrotation volvulus is black and white, and people struggling to do any possible imaging modality to improve the diagnosis. And actually this is more and more used but it is also showing some pitfalls and some false negatives. But one has to know what's the normal duodeno-jejunal junction. That's what we're looking for. A straight frontal view, patient is straight as seen on the vertical pedicles of the spine, and contrast is followed, and the duodenal sweep come to here, and this is the duodeno-jejunal junction, which should be projecting at the same level as the duodenal bulb. The more important feature is the lateral view that one has to watch at the beginning, and watching this wagon of the train of contrast medium. It is posteriorly located, that means it's retroperitoneal. So that's how we make sure that there is a normal fixation of duodenum. But you have to be aware of some variants, the so-called duodenum inversum, where actually duodenum is opacified, D2, and then D3 is ascending toward the head here, before crossing at this level. So the duodeno-jejunal junction is in normal location, but we have these variations. And on the lateral view, this is still a retroperitoneal. Or you may deal with a redundant duodenum, and then you demonstrate the duodeno-jejunal junction here. So those are normal variants. One common feature is that the proximal duodenum is not really dilated, because dilatation would imply strongly possible obstruction. So let's look at the causes of duodenal obstruction. To make it simple, think of intrinsic versus extrinsic causes. Intrinsic causes: atresia or stenosis, web, diaphragm. Classical authors speak of windsock deformity to refer to the dilated proximal duodenum, which with the pressure of the alimentary and the liquid pushes further down the duodenum and may make someone think that the obstruction is further down the duodenum, where it is just probably at the D2 level. In terms of extrinsic cause, then one has to remember the Latz band, responsible for the Midgut volvulus, which is a complication of malrotation, and then all associated features such as the annular pancreas or abnormal veins in the upper abdomen, and do not forget possible duplication of the GI tract and rare case of duodenal hematoma. Let's see a few examples of those entities. Here we are dealing with the duodenal atresia, classical double bubble, when some clinician would request a contrast study. Well, then same thing, double bubble, nothing goes through. So surgical entity. Here we are dealing with the duodenal diaphragm. It may have one or multiple openings, so it's central or eccentric central. Then you recognize this focal dilatation proximal to that level, and the beauty of it is it signs the diagnosis here. The surgeon, when he's dealing with obstruction, anyway double check the lumen and the patency by running a catheter through the duodenum. So then they may meet a missed duodenal web or diaphragm by imaging. Of course, we would look for the associated possible vascular anomaly, like here we see the SMV is anterior to the SMA in this case. Just double bubble, a classic image for duodenal atresia. Now, malrotation, we know that it's related to the failure of the midgut to rotate around the SMA axis during fetal life. It's a frequent entity, 1 in 500 live births. May be isolated, but often in our hospital see it associated with a lot of congenital anomalies, vascular essentially, or heterotaxia. And the symptoms are related to the mechanical obstruction. suddenly with a volvulus, or because the presence of peritoneal band. Rarely the bowel loops are actually involved into an internal hernia, or there may be a combination of. So the fixation of the midgut, we know there is a stalk. It's fibrous, it's peritoneal band, the so-called lat band, which normally attaches the right colon to the abdominal wall. What happens in malrotation is that band actually is linked to a malpositioned cecum, and then it goes across D2 and D3 portion of the duodenum to the right paracolic gutter, and the root of the mesentery is short. The shorter that mesenteric root, the worse, the more severe is the problem. Showing you here a case of a neonate with bilious vomiting. So we do no pacification with an NG tube in place. We watch that there is no dilatation, and then we have two main signs to take from here. We follow the outline of the duodenum. Well, this is a big and then a circle. That's the beginning of the corkscrew sign, enough to send the patient to the OR. And then we have some contrast went through. The duodeno-Jejunal junction is not here, but to the right side. Okay, so two main important signs. Now the volvulus, surgeon would tell you it's maybe 3 turn, maybe 2 turn, maybe 270 degrees. So the volvulus could be more or less loose or tight or multiple. This is important because it happens that volvulus could be transient, and then there is a devolvulus, similar to the torsion and detorsion of a testicle or of ovary. Here, by ultrasound approach now, this patient had on 2D imaging something like a donut sign, but one would do a color Doppler to identify the vein with duplex tracing, which circles strangulated the SMA, the so-called whirlpool sign. Another picture with color imaging here, and the classical exam when I do exams on the lateral projection and I start watching this proximal duodenum. Here it's so tight that I have the really corkscrew sign of a volvulus. Now this is to illustrate the importance of a lateral view in upper GI. Here is an example of a normal duodenum, lateral projection. I'm watching the duodenum, D2, D3, it's still posterior retropenoidal, it's fixed. In case number 2, the duodenum starts wandering, going anteriorly, and then here it's lost, it's not fixed. This is malrotation. Now here, I have an obstruction, it goes more anteriorly, we are still lateral projection, and then you have this subtle sign, just like a beak. That's the beginning of corkscrew. We turn the patient on AP projection, and that's the circle here, the whirlpool. So very important to follow the duodenum opacification with the patient on his side, to follow the management, the behavior of duodenum, and then turn the patient AP to document the location of the duodeno-Jejunal junction, if there is opacification. Otherwise, you will see that corkscrew sign. So, to finish with malrotation images here, pitfalls. For instance, this one here. I'm following, I'm getting D2, D3, D4, some jejunum, but this is too low because we are taught to have the DJ junction at the level of the duodenal bulb here. Well, think of possible mass effect for either splenomegaly or dilated bowel loop in this level, or even the NG tube when it's not NG but NJ, nasojejunal tube. Because of its stiffness, it may push down the DJ flexion. It happens, so one has to be aware of this possibility. Now we get some variations of anatomy of the duodenum as the counterclockwise so-called barber pole sign, actually described in adult literature because of the CT indications, where then one will look at the SMV. The SMV turn, but in a counterclockwise around the SMA. And actually this is just an anatomic variation here, and usually there is no midgut malrotation in this case, because most of the mesentery is the small bowel, and this mesentery are more to the left here. Here another example of a newborn, billous vomiting, here dilated, and then have the beginning of a corkscrew sign. There is no duodeno-Jejunal normal location here. On ultrasound we have that whirlpool sign. If you put color Doppler, you will have the vein and the artery in a clear fashion. Now, caveat, because with the advent of ultrasound, people were hoping that with ultrasound we clear the problem. It's not real. Because, for instance, I'll show you that a normal sonogram does not exclude malrotation. It gives us a false sense of confidence. For instance, in this case, the vein and the SMA are reversed in positioning. Then we call it abnormal. Yet, here, the baby has proximal duodenum dilated, and there is a malrotation, malfixation, for sure. In this case here, the SMA-SMV relationship are normal on a transverse ultrasound. Yet, when we do here, we see it complete obstruction. So it's good. But in this case, the SMA-SMV were abnormal. When we did the contrast study, there was a redundancy, but the duodeno-Jejunal junction was followed up to here. And this adds up to many cases where we are not always relying 100% on the normal SMA-SMV relationship, especially when the patients are vomiting. So we have to think clinically. The patient still has the problem of vomiting. Refresh our memory again. The corkscrew, and then here corkscrew on lateral view. Now, surgeons, clinician may request an enema to assess malrotation. One would say, why? Actually, on plain film, one would take this, the small bowels are a little bit abnormal. When you see that sign, it may suggest there is a problem with malrotation. When you do the per GI, we have the beaking, but the emergency of it, of course, directed by the clinical situation of the patient. But sometimes surgeons try to gain some time, ask us to do a colon study, and if we demonstrate a normal fixed cecum in the right lower quadrant, then the implication is that the mesenteric root is wide. Likelihood of volvulus is less. But in this case, we see, consistent with the volvulus here, that the cecum is high. You see where it is? So the root is short. The root of the mesentery is short. And that's what explains why the volvulus occurs so rapidly in very early life. I'm showing you these challenging cases because this baby had heterotaxia. The stomach is on the right side, and he was not only vomiting chronically to a point that he was malnourished with ascites. So he was fed with G-tube here, yet contrast study demonstrates that the duodenum patient is not prone, it's supine, but dextrogastria. Duodenum on the left, one would think that you expect the duodenal junction here. It's not the case, it goes here, so it's not fixed. I'm showing this case because this one actually spent many weeks in hospitals because of ascites, which was chylous, and people were thinking about malabsorption. Yet the chronic volvulus, devolvulus, volvulus, devolvulus causes the problem with venous congestion. That's why the patient was malabsorbing. So one has to recognize as a possible cause for chylous ascites a chronic intermittent volvulus of malrotation. I'm quoting this recent paper by a pediatric surgeon from Yale University. They summarized the thinking of what should we do in terms of imaging in malrotation. So, plain radiographs, it's inexpensive, it's quick. Well, there is some radiation, but if we don't recognize the sign, it may delay the treatment. And of course, plain film by itself cannot exclude malrotation, so we have to do more. Well, ultrasound is handy. No radiation exposure. We know about the possible whirlpool sign. One would study the D3 duodenum, which would cross in normal situations the midline, and also knowing the SMA-SMV relationships. So, but we've seen cases of false negatives, so it does not exclude total malrotation, and ultrasound is operator dependent. Contrast edema, I just show you a case where clinician would like to see where the cecum is. Well, it adds some radiation exposure to the patient. If we do see a normal cecum in the right lower quadrant down in that corner, less likely we have malrotation with volvulus. Even CT was analyzed because it may show the anatomy, it may show you the whirlpool sign, but it's high radiation, and again, a normal SMA-SMV relationship cannot exclude malrotation. MRI, tentatively tried, but actually not really, because it's expensive and there is a question of accessibility, and we need sedation, which is another complicating feature. Of course, it's handy if it shows those anatomic features. The bottom line is surgeons and radiologists must cooperate. One has to be confident in the ability of the other, and actually imaging algorithm should be adapted for each institution. In some hospitals, radiologists are good fluoroscopists with experience. We have to depend on that. In other places, ultrasound is very brilliantly performed, and then it shows every sign that I just described to you. Now, how about other causes of obstruction? GI duplication. This baby is 16 days old, double bubble on prenatal ultrasound. So we think about duodenal atresia. Well, ultrasound is done, and it shows that fluid film with a so-called bowel wall signature. Okay, so bowel wall signature means it's the duplication which is obstructing the GI tract, and this is one common site of GI duplication. The other common site would be in the right lower quadrant. A rare case of annular pancreas. This is not a specific entity, but oftentimes it's associated with the other process of malrotation and volvulus. In this one, 12-day-old newborn, billous vomiting. So we have to do a contrast study, and then we have a duodenum proximally dilated. We wait, and then we get some narrowing down here. And actually the pancreas is just encasing that portion of duodenum. Important feature, polyhydramnios. So this is a serious disease that one would anticipate postnatally to operate surgically. Another case of duplication cyst, typical location near the pyloric, and then the bowel wall signature. At this point, a contrast study was done, and one would be impressed by the mass effect that we have at the pancreas. It's not the pancreatic mass that one would see in adults, but in this case, the duplication cyst operated on. Following this vomiting clinical scenario, now let's turn to the issue of abdominal distension of the newborn. And actually, many causes of abdominal distension. We cite too much air, fluid in the peritoneal cavity, bladder distension, then we have the GI tract, not forgetting visceral mass or visceral megaly, and then pathology in the peritoneum, GI tract, meconium plugs, Hirschsprung disease, left colon syndrome, premature baby, and then finishing up with necrotizing enterocolitis, sick baby, or the big issue of ano-rectal malformation. For instance, this baby has esophageal atresia with T fistula. Reproval is to drain the secretions to avoid possible complication of aspiration pneumonia. Yet T fistula area is seen here, and we have many bowel lobes dilated. The patient has jejunal atresia. So one atresia will hide another atresia, which may hide the ano-rectal malformation. In this case, 3-day-old, abdomen distended, many bowel lobes, some fluid levels, so discrepancy in caliber, few bowel lobes. We think about small bowel disease. This case was jejunal atresia. Then, because many bowel lobes, one would perform enema. It shows the colon not really used, and then we have small size of distal ileum, but the gas-filled bowel lobes in jejunum are still dilated. So the process is not in the colon, it's not likely in the, it's unlikely in the ileum, but in the jejunum. To refresh our memory about the surgical classification of small bowel atresia, type 1, it's membranous. Type 2, we have a fibrous core. Type 3, we have the defect with some defect at the mesentery here. Type 4 is then becomes more complicated. The worst would be like the upper peel syndrome, where one would see just a residual upper peel as a remnant of distal small bowel. How about other etiologies now? Meconium ileus. It's usually an ileus dilatation of small bowel because of meconium pathology. This is a full term. He has abdomen distension and failure to pass meconium. A lot of bowel gas distended. We do an enema and we see a not used colon, the so-called microcolon. We are able to contrast or pacify the small bowel, and we see a lot of filling defects. Those are the pellets of abnormal meconium. So classically, this contrast enema is water soluble, slightly hypertonic. In our institution we use cystoconylate 2, the same amount contrast that we use for VCUG. Hand injection, smooth catheter with no balloon. Actually, in very sick patients we use the omnipaque solution because it's non-ionic. Hand injection, simple rectal catheter, and it helps actually decrust the sticky meconium from the bowel wall and unplug the patient. If mucomist is to add, that's the solution that we use, because we have to use a 5% solution mucomist. The pharmacy in our institution gives us a solution, 20% solution, so we have to do the correct arithmetics to give the right amount and concentration, because one has to be careful about fluid overload and the hyponatremia, which could cause seizures. Now in the full term, this one is 2-week-old, distended abdomen. He vomits because we have non-specific dilatation of bowel loops. Enema is performed, and the conventional study is lateral views, which gives you, if positive, diagnosis, as in this case, recto-sigmoid ratio. This is a transitional segment. This is a classical textbook picture of Hirschsprung disease. So it's nice to know this image, but I could tell you from the beginning, Hirschsprung disease mimics a lot of entities. Let's see this one. Bilious vomiting, but no meconium evacuation. So bilious vomiting, you think about contrast study from above. No meconium evacuation, especially with this dilated loop. You have to think maybe I should do a contrast enema study. Air fluid levels, there is no pneumoperitoneum, no abdominal mass effect, no calcification. Look what we did. An upper GI study, quick one, we demonstrate that duodeno-Jejunal junction is normal. Then we go to the second step, contrast study. Now here we opacify. Here it looks like meconium, and the differential diagnosis includes total ganglionosis coli, which could look like this one too, or even ileal atresia, but because of the gas distension. So be careful. A microcolon, you have to think it could be Hirschsprung disease or a obstruction at the small bowel, the main entity being ileal atresia and meconium ileus. On this one, baby born to diabetic mother, important, C-section, so he's suffering, he's in metabolic distress. A radiograph, well, we say it's a normal one, but the patient did not have meconium passage, so there's a functional physiologic problem there. Yet we have to do studies to exclude organic pathology, so we do the enema. One has to be aware of this discrepancy in caliber when we push versus the diameter of the transverse and right column. Actually, there is no transitional segment at the splenic flexure, which means less likely Hirschsprung, but because of this clinical setting, we call it left colon syndrome. This is a newborn, premature, distended abdomen. Radiographs, well, it's not really normal, but not really abnormal. But he is not tolerating enough milk. So food intolerance also add the discussion of possible necrotizing enterocolitis. So an enema, safely injected hand injection, shows rather normal colon. Here we have meconium evacuation through the urethral meatus in a newborn. The plain film, abdomen distended, especially this bowel loop. But one has to look at everything in the film, and three signs to recognize: the dilatation of the bowel loops, the air fluid levels, we are dealing with the obstruction disease, and the sacrum dysplasia. Close up, see that you have sacrum problem here. Of course, clinical information I just hide from you, but the patient has ano-rectal malformation. This is another entity where one has to start doing extensive workup, because implication of a fistula has to be identified. This is recto-urethral fistula because the patient had colostomy. We opacify the distal loop and we demonstrate fistula. And also the workup should include a VCOG. VCOG here, we have an abnormal kidney that may quickly be identified on ultrasound, and with reflux here. So left kidney malrotation, via reflux, frequently associated ano-rectal malformation. Lumbar spinal canal ultrasound may show you, like in this case, a lipoma in the filum terminale. So to summarize, this is a more recent case. The bladder is here, ano-rectal malformation. This is a dilated pouch filled with meconium. We do an ultrasound. Thank God for this patient, did not have any spinal cord or no tethered cord. So no spinal cord anomaly, no lowering of the distal cord. We do VCOG, the urethra is normal, but we demonstrate a fistula that later on with lupogram from the colostomy is filling the fistula, and the bladder is filling in a retrograde fashion. So this is the combination when you do lupogram and then VCOG, the so-called fistulogram. Here is an example of the premature baby now. Pathology of the premature baby, the episodes of oxygen desaturation. So he's in ischemia, and then he gets abdominal distension. Plain film. Well, it's easy to recognize once we know what is this, the falciform ligament, because air is on either side. So he perforated. This is the film that one will obtain, left lateral decubitus. One would wait a few minutes to get the gas collected here. And you see that you are manipulating the patient. If he's intubated, you risk dislodging the ET tube. So, free air in pneumoperitoneum. We know about necrotizing enterocolitis. It's a combination of a lot of stuff. Dysmotility, circulatory problem, hypoxia, ischemia, immunology problem. So all this consortium results in necrotizing enterocolitis. Now, Bell classification clinically stages it as suspected disease stage 1. Actually, for radiology, there's nothing specific. The X-rays look fine, but clinically, patient has all those in temperature instability, becomes distended, he gets gastric residue, he may start having bloody stools. Stage 2, the so-called medical stage of neck, where we have worsening of the systemic signs. On X-rays now, it shows maybe pneumatosis intestinalis and portal venous gas. Actually, laboratory-wise, the patient is not doing well because he has acidosis and may have already is going to thrombocytopenia. Stage 3, we don't want to see that, but it's a surgical stage because you have free air. So peritonitis, abdominal distension, hypotensive. So the role of imaging is either through serial radiographs to try to find out those pneumatosis, portal venous gas. Unfortunately, when you see pneumoperitoneum, ultrasound has shown really increased accuracy and sensitivity in studying the bowel loops, the pattern, its vascularity, its peristalsis, and also the quality of fluid that we see in peritoneal cavity. Clean versus when it's echogenic. It's really ominous sign for perforation. Let's see examples of that. Because here clinically concerned, we suspected treatment, workup, NPO, definite disease, keep the treatment, advanced disease, we have radiologic signs, free air. The bowel loops on serial radiograph are fixed because there is a lot of inflammation around. We do see portal venous air, and there is ascites most of the time with echogenic content. So the abdominal radiograph, don't hesitate, we get 2 views at least for the beginning, and then the concern about radiation exposure comes, and then one elect probably to have 1 view each time, either supine and then across table, to try to define free air versus status of the bowel loops. Now we look at the gas distribution and also the wall thickening or the apparent loop separations, and from ultrasound we have to get for a fluid presence or not. Let's see examples of it. Here, abdomen, but one would be worried about this bubbly gas here. Pneumatosis. Cross-table lateral view is elegantly showing the triangular shape. Air has escaped. This is perforation. One will not recognize it here as easily. So the value of cross-table view is here. Ultrasound. I mentioned the very superiority of ultrasound to demonstrate the large, rich semiology. You have to have a good state-of-the-art equipment with linear transducer, and then it needs a little bit of learning curve to be confident in assessing the bowel loops and also the peritoneal cavity, looking for the air in the wall, outside in the portal vein, and free air, and also looking at the status of the bowel loop. Is it viable or not? That means you use the colored Doppler as well. So this paper shows nicely the physiopathology and also put the emphasis on the ultrasound analytic imaging in case of necrotizing enterocolitis. If you put a grid, those items have to be searched systematically. Gas in the wall, portal venous gas, and the free peritoneal gas, which we recognize. The abdominal fluid, anechoic or echogenic, and the status of the bowel wall. Its thickness, is it echogenic? Are the bowel moving? And the perfusion on color Doppler. Few examples. Here we are dealing with a baby sick, acidotic. The bowel loops are dilated. Bend one hand, look at this portal venous gas. Here we have some fluid accumulating in the perineal cavity. The bowel loops are separated. One may think the bowel wall is thick or there is fluid around it. But the pattern is that there is something going on here, and ultrasound could easily sort out what we see here. Here one will look for the intramural gas. They are nice examples of linear pattern of intramural air here, and here it's a more bubbly appearance. In this baby that young, it's not feces with air mixed, but this is suspicious for the submucosal gas in all the circumference of the wall of the bowel loops. On ultrasound, one has to get high linear transducer and be patient and observe the bowel loops in all quadrants of the abdomen. Here, luminal air, this is content. One would watch the thickness of the bowel, and those are bubbles. So intramural versus intraluminal air. On plain film, this is portal venous gas. When you do put the probe on the liver, you see the portal venous gas in the liver, and we know it's dynamic, so you see it acting. Well, one would not like to see this because this is free air on cross table view, or the triangle shape escaping air. Now here it's obvious that on plain film we see the so-called football sign. It's already late case. The perforation is really with a large amount of air, and you see that the patient has respiratory issues because it's a baby with early premature, and 18 days of age is developing chronic lung disease of infancy. Now let's focus on the bowel wall itself. One would think of the thickness. Here it's thickened, it's homogeneous. We don't see the layer of the echogenic layer of the submucosa, mucosa muscularis serosa, but it's homogeneous, thick edema. You see surrounding the mesenteries edematous. Versus the bowel loops are dilated, but the wall tend to be thin. So thinning is not a good sign, especially that here the fluid is in the peritoneal cavity. It's echogenic. It means cellularity, either hemorrhagic or infectious. Here on Doppler, you see the power of color Doppler. Here some bowel wall is vascularized, but this loop is not moving. It's echogenic. It's dead, necrosis. So this is an important sign to tell the surgeons, because you know this is bowel dead, and most of the time it's confirmed on surgery. Now we will come to conclusion about the issue of intestinal obstruction of the newborn. And this is a recent paper which make it as a scheme to maybe for good memorization of the pattern when it comes to bowel obstruction in newborn. Normal pattern, that's what you like to see. Double bubble, single bubble, triple bubble, you name it. Here we have a discrepancy. Proximal dilatation, few bubble air distally, or double bubble and this, or dish. This is diffuse dilated small bowel loops, and this is scattered bowel loops. Now when it comes to contrast, one would like to have this image with the junction left to the spine at the level of the duodenum, pyloric duodenum. Here We don't have good DJ junction. This is malrotation. This is the corkscrew image. This is like a beaking. It implies here the beginning of a corkscrew or a severe stenosis or obstruction, the duodenum. This is maybe partial obstruction, probably if there is an extrinsic compression, or in case of duodenal hematoma, that would be the pattern. When it comes to colon, microcolon, or more correctly, unused colon, means disease, it's in the small bowel. Here, short microcolon, probably here we have an atresia. Here, if the colon is small, and then here, if you have a transitional segment, this is probably Hirschsprung to that level. If you don't see any transitional segment, probably this is the left colon syndrome. Normal colon. This is diagram from the same paper where from plain film you end up doing upper GI or contrast enema, and then depending on what the information you get, you may elect surgery or non-surgery, but those are important surgical entities which most of the time is surgical management. Here ultrasound should be put in that place, especially in the upper GI tract, and of course this is just a general value of the abdomen radiograph, but we've seen examples where ultrasound is very handy for malrotation, for volvulus, for pyloric stenosis. So to finish up with some pearls, trisomy 21 patients are more likely to have Hirschsprung disease and duodenal problems as well. So when you have trisomy 21 patient, don't stop because you thought you find the problem of Hirschsprung. He may have also, I tend to say, like Hirschsprung of the duodenum, he has the functional problem with the duodenum as well. When we see intestinal atresia, think of vector association, and then the whole imaging workup is done with sonography to look for other congenital anomalies. The case of meconium ileus, it's because it's an abnormal meconium. 99% of the time is cystic fibrosis. So in conclusion, few essential points. We've seen clinical features, when we get them from history, help us orient our thought process. We saw radiographs, basically two views, can give you the location of the level of the GI tract obstruction. Ultrasound, very good for pyloric stenosis and to demonstrate the volvulus malrotation. Now, bilious vomiting, until proven otherwise, think of surgical emergency, the volvulus. So, if we have a GI obstruction syndrome, quickly we have to go beyond the radiographs to decide, do we do an upper GI study or a contrast enema study? Simple meconium ileus, we've seen it that we may treat the patient, and we are asked actually to repeat enemas, therapeutic enema, to unplug him. But be careful of the hyperosmolarity of the contrast and the risk for hyponatremia. Radiographs and contrast enema may suggest Hirschsprung, but it's always mimicking other entities. So in case you're not sure about Hirschsprung, rectal biopsy is a must. And we've seen that ano-rectal malformation could be deciphered with sonography for the GU tract, for the spinal column, canal, lumbar level, and also with the other contrast studies, VCUG and